uh, Allan Abbass from Dalhousie University, and I'm just going to present a bit of an overview. It's interesting. I think I've been doing an overview on this in a research panel since we started having research panels. I don't know how many times ago, but there's an increased amount of research as Peter pointed out earlier. There's a lot more research in ISTDP and EDT methods over the last 10 years. So this is, there's a couple of articles that are relevant here. And one is that we have an online article. It's almost 40 pages long of all the outcomes evidence and process evidence in ISTDP that you can get off my website. So that's updated a couple months ago. And we have a new review of the evidence and methods for somatic symptom presentations of interest, and that's impressed. Amy Harguri and I did coming out in a journal of neuropsychology very soon. So, in overview, the evidence goes back to Dr. Davalew's work, his pioneering research with videotape case study, following up patients to develop the treatment methods. And there's around 150 published outcome and process studies now, including around 70 randomized controlled trials. And a large number of these are of treatment refractory and complex patient populations, which I think is something that, in a sense, sets apart this model from other modalities in terms of the range and scope of application. There are over 50 somatic symptom study papers, and we're going to go over this further in a minute. 25 more on cost effectiveness. We found it outperforms CBT, traditional CBT for chronic pain in a small number of randomized trials, and there are about 25 process studies, and there's broad utilization. So the American Journal of Psychotherapy, we have a special edition coming out. There's going to be a review on cost effectiveness, amongst other reviews that are coming out soon. So around anxiety disorders, I just counted up the numbers of studies so you'd have a bit more in there, but there's 17 randomized controlled trials for anxiety disorders. And there are, I believe, 3 or more on just social anxiety disorders alone in independent research groups. And you can see here some on OCD, panic disorder, generalized anxiety disorder. And there's one study of mixed anxiety disorders in new therapists that was conducted in Italy. This is one of post-traumatic stress disorder. You're seeing here cost effectiveness data along with treatment effects. So this is for PTSD. This is total doctor and hospital costs going from high down into the normal range and staying there in 3-year follow-up. This is very important information and large effect anxiety reduction. This is GAD, similar looking effects with an 8-session treatment average. And so there's those are just 2 of the studies with graphics that I have. The mood disorders, there are 13 randomized trials for mood disorders, several for major depression, 2 for treatment-resistant depression. And if you look at the evidence for treatment-resistant depression, there's very few randomized controlled trials of anything in psychotherapies. There was a Cochrane review done, I don't know, maybe 8 years ago, and I think they only had 7 studies of psychotherapy. One was our randomized trial led by Joel Town. But now there's a brand new one just came out last year. You can consider it like a type of replication study, and both showed good benefits compared to controls. This is our Halifax treatment-resistant depression study. This is the early data. This population is so tough. 90% had personality disorders and 90% had chronic medical illness. They had 16 sessions of treatment. And you can see here the population was so tough that there were 30 patients in each arm. And in the mental health treatment, they were getting increased medications, they're getting psychotherapy, mostly some CBT elements, and only one patient on their arm remitted in the 6-month follow-up. Just tells you how tough the population was. And it was like 12 or 11 or 12 that remitted in that short follow-up. And then the follow-up data, the community treatment had as many treatment sessions as ISTDP did. And there was a persistent of added benefits. There was evidence of more cost effectiveness. And ISTDP had less follow-up treatment, less medications. So,
Can I ask a question?
sure.
On that, if you could go back to the last slide on the treatment resistant, what kind of treatment were the treatment resistant cases that
Yep.
weren't in ISTDP? What were
The
they receiving?
medications and psychotherapy, mostly elements of CBT.
The newer treatments are TMS and ketamine for that group, so they weren't receiving those treatments.
Oh, this was done in this patient treatment was done like up to 2012.
Okay, so
Yeah, there wouldn't be any ketamine in there. These were outpatients as well. So these were outpatients referred to the treatment teams in the community. So that's a little select sample. If we had a hospital sample now, some would definitely be having ECT and all kinds of things.
Well, we're having the new input is the Stanford protocol of TMS. That's like the rage in our community.
Yeah, I'd love to see how it stacks up in a study at some point.
Yeah, so that's what I was curious about. We did in that part.
So, and this is the other recently published randomized controlled trial for treatment-resistant depression. Here they found large effects in post and follow-up compared to a wait list. So a wait list is they're not getting any specific treatment added. So it's a different, it's an easier hurdle to jump in a sense. This is for psychotic disorders as an adjunct. So you add it on to existing treatment. Dramatic effect on hospitalization costs. This is a huge difference here. 25,000 a year a year before, and doctor billings normalizing and persisting in 4-year follow-up. Average was 13 sessions. And what was interesting, there was a 50% drop in paranoid ideation and self-report, significant reduction. Bipolar disorder, similar as an adjunct to gain, long-term cost effects evidence. So you're just improving emotion regulation, and it helps people to function better, gives them less odds of being hospitalized. So you help deal with some issues related to losses and trauma to some degree, and it helps them function better in long-term follow-up. The personality disorders, there's 6 trials, 6 randomized trials, and several other different kinds of studies. This was ours, RCT. This RCT is probably arguably the best test of ISTDP for this population because all of the therapists, just looking if one of the other ones was here, one was Alan Kelpin, and Terry Sheldon. So they saw patients as well. So all these therapists had to have at least 5 years of training with Davinu. So and Davinu reviewed the video on some of these cases himself. So he gave supervisory input on some of these cases. This is as good of an evaluation of that. This is a supportive short control where they got follow-up meetings and persistent effects in long follow-up. And also there's evidence of cost effectiveness in that. This is a somatic symptom data, 30 RCTs. This is a huge number. And this, so you can see here, like huge number of different conditions, kind of head to toe. Several, I think there's 19 studies of chronic pain alone. And there's a couple RCTs on headaches and mixed jaw problems, pelvic pain, urethral syndrome, skin problems, bowel problems, basically the whole, every organ system. This is our study Peter published with us on chronic pain. And again, you see this nice cost reduction effect. Functional seizures, Leo Russell led on this for us. And functional seizure group, it's interesting, I think it was only 5 sessions, but it doesn't take many sessions to help people use the healthcare system less and reduce the amount of symptoms they get and have them have some understanding of it and be able to tolerate things better and regulate better. And there's more studies than just this. There's just a few. This is one that was a key study for on our service on emergency visits. So this is people that kept going to the emergency department. They went an average of 4.5 times a year. That's like 5 times the normal population rate. And with 4 sessions, average is a 70% drop in emergency use. And that's was designated as a Canadian leading practice, kind of a standard from that. And this is a just published randomized controlled trial led by Joel. And here you see the control group versus the ISTDP group. They had a similar, very interesting 65% drop in emergency use. So really similar to the naturalistic data. This is somatic symptoms reduction. This complex and refractory populations, I mentioned already bipolar disorder and psychosis as 2 of this group, but eating disorders is another one. Dion, who presented on this on eating disorders yesterday. There's some healthcare cost reduction data as well. We didn't have a published like a specific eating disorder measure. That's a kind of a gap for ISTDP. It can be applied along with the other elements you need to do with eating disorders that go into food and behavior and other things often. This one here is super important for people working in the hospitals, and we applied ISTDP on a ward, 10 sessions. These are people with psychosis, anxiety, bipolar disorder, personality disorder. They had significant reductions on the measures, and their ECT use on the full ward dropped by 65% when we had the therapist on there, embedded into the team. She would go to the rounds, you know, they would help, and she saw a lot of their patients, like a large portion, I don't remember what it is. And they ended up with a shorter length of stay on that ward. And the cost, basically, the psychologist was offset by reducing ECT costs. This is Kees Cornelson's study, Netherlands. These are, if you've ever haven't seen his presentation, he's very severe populations, 10-year follow-up data. This is, I think, the longest follow-up data that there is on this is on this is symptom measures, and also the same for function. Norway program, 8 weeks for treatment-resistant disorders, evidence of cost effects, and symptom reduction and interpersonal improvement as well, with large effects. So this is a nice program. It's a day program. I think most people went home on weekends. These are expensive programs, but when you can show cost effectiveness, it should help with the government. And I've kind of already showed cost effects data already, but this is the data of, this is the largest study there is published, 890 patients, 57 therapists. That's where Robert's case data came from for depression, and these other cases came from this big data set. Process studies, there are quite a few, and there's more coming. So, for example, emotional experiencing linked to symptom reduction, experiencing anger linked to reduced depression, the next session, handling things of the impact of handling defenses, sequences of processes, the level of activity of the process, outcomes being different by spectrum. That's another one. So this was like, there's, I think, 6 studies on unlocking now, and impact of major unlocking on healthcare costs. So better reduction on doctor costs if the person had an unlocking compared to if they didn't have an unlocking. Wasn't a significant difference in hospital. This is one on during the trial therapy. This is Peter Lillingren's data, that there was a difference if they had unlocking, this unlocking, not unlocking. and difference on outcomes on both symptoms and interpersonal problems. Same here for the overall treatment course. Significant differences if they had an unlocking versus they didn't on symptoms and interpersonal. And this is the data already that Robert just showed us. So that's a brand new publication. And there's more things than that going on, but it's a little bit of an overview to say that if you're working within this model or doing your best to do so, you're using an evidence-based approach that meets, various criteria of different kinds of standards for efficacy. And I think it's amongst the best studied of the short-term dynamic models. And I mean, the long-term dynamic models have very few randomized trials, so it's up there as one of the best researched models right now.